Hi, my name is Connie Clark, and you're watching the video on the etiology of exophorias. So there are a variety of reasons why a patient may have an exophoria. And when we're talking about etiology, we're talking about patients who have exophorias with no symptoms and exophorias that may become decompensating. So in the past, we've talked about age and the way in which the eyes have a tendency to diverge as the individual becomes older. And this therefore puts us at more of a likelihood of developing an exophoria as we become older. Or if the patient already has an exophoria, it could increase in size. Now, there are anatomical reasons why some patients will have an exophoria over an esophoria, for example. And one example of an anatomical feature that leads often to an exophoria is a wide interpupillary distance. Patients with exophthalmos also may have a greater tendency towards an exodeviation. If a patient has a paresis, so an ocular motility disorder where the deviation size changes pending the direction of gaze, can also lead to an exophoria. And then there are a variety of refractive errors which can lead to an exodrift. And generally we're looking at type of refractive error where we have a reduction in accommodation and therefore a reduction in accommodative convergence, which is why we see these exophorias. So what we see here with myopes, high hypermetropes and presbyopes is that in all these instances, patients are not required or do not do as much accommodation as other individuals. So a myope tends not to accommodate near as much because they can see clearly. A high hypermetrope has difficulties accommodating to overcome the hypermetropia, so they hypo-accommodate. And then you've got your presbyopes, which obviously in this instance, we have changes to the lens where we're not utilising as much accommodative convergence or accommodation, which leads to accommodative convergence. Okay, other issues can be around anisometropia and anisoconia. They too can lead to patients having an exophoria. Here we have a few other reasons for a patient developing an exophoria, and these are often factors that may lead to decompensation, so patients now struggling to control the exodeviation. So one is the optical correction of refractive error. If there's been an incorrect prescription provided, then that can lead to the decompensation of an exophoria. If the patient's glasses are ill-fitting, so if the lenses in the glasses create a prismatic effect, which then creates a disruption to fusion, obviously your patient is going to struggle controlling the original exophoria now with these ill-fitting glasses. Okay, medical reasons can result in patients decompensating, and this is when a patient has poor general health. If they've had some kind of trauma, a head trauma in particular, which then disrupts their binocular functions, and certain medications and alcohol can also influence a patient's capacity to control an exodeviation. Other reasons that can lead to an exophoria decompensating is that there is all of a sudden increased activity which is visually demanding for the patient. So if, for instance, as an example, a patient has a job where they have to look down a microscope continually, that could lead to a decompensation of an exophoria, because what you're doing is you're dissociating the eyes continually, which leads to prolonged dissociation and a struggle for control. So given these sorts of reasons, when a patient presents to you with asthenopic symptoms, you need to ask questions around whether there's been any change in occupation or job or visual activities that coincide with the symptoms presenting, or asking the question around when do those symptoms occur? Is it after a long period of reading or using the computer, as an example, so that you can then decipher whether there is an activity that is contributing to the difficulty the patient is having with control. Okay, that brings us to the conclusion of this video. Thank you for watching.